All right. What a great day. And thank you so much, Dr. House and Dr. Majerzik, for providing us with all that very usable information. Our last lecture of the day is Dr. Chris Hammond. He's going to be speaking on Parkinson's disease and other tremors. His lecture was generously sponsored by the Ogden Clinic, so we just wanted to thank them for that. Dr. Hammond is a graduate of BYU and received his medical degree at the Western University in California. He completed a neurology residency at Northwestern University in Chicago. He has practiced with the Ogden Clinic for more than 7 years and has a clinical interest in multiple sclerosis and sleep disorders. He is on staff at McCady Hospital and serves as the stroke director at Ogden Regional Medical Center. He, his wife, and 2 kids can frequently be seen jogging, enjoying the trails all around Ogden. So let's go ahead and welcome our last lecturer of the day, Dr. Hammond.
Well, in there. Thank you. Thanks for sticking it out with me. The enduring type. We'll speak about neurons and endurance. Now, I've never had a sponsor before. I didn't know that until I got up here. I'm sponsored. It's a great opportunity to be here. I appreciate it. And I hope I give you some useful information on kind of up-to-date information regarding Parkinson's, but also what kind of plagues all of us, including neurologists alike, is what to do about this tremor. What kind of tremor is this? What is this going to lead to? Is this benign or not so benign? I think this is a common question most clinicians have as patients come in shaking, the shaking syndromes of many types. Disclosures, a few. I have received funding from various Parkinson's drug companies, but mostly Starbucks. My goal is to understand tremors and different tremor types, review some of the PD pathophysiology, which is a very interesting topic in evolution, quite more so in development understanding, but not so much with treatment, as we'll get to. My focus today really is a great interest of mine. I wish to discuss are kind of the premotor or non-motor symptoms of PD that largely is underappreciated. So if my goal in anything today is that you walk away understanding the more or less premotor symptoms of Parkinson's disease that are largely underappreciated to a great extent, but more and more data suggesting that we should be paying attention a little bit more. And of course, we'll review a few of the treatments, again, not revolutionary in the last few years. So what do we think about tremor? Many different types of tremor, from physiological to non-physiological, but everything in between. So we have tremors that are dystonic, tremors that are more of the typical Parkinsonian tremors, which we're going to weigh in heavily on this discussion, of course. But we need to understand there's many different types of tremors, including from nerve to muscle problems, medications, and other toxic elements as well. And then we can look at more typical essential tremor, again, probably primary, secondary to Parkinson's, depending on your literature. And what type of essential tremor is that? Is that task specific? Is that related to orthostatic and so forth? And dystonic tremors alike. So then we look at the etiology, passive classification of tremors. And the etiology is quite extensive. This list here is not even nearly comprehensive. And so just listing the more common variety, including hereditary Wilson's disease, degenerative such as Parkinson's, of course, essential tremor, metabolic, which we look at thyroid, parathyroid including, in addition to liver, which is quite common for those that do have hepatic failure. Peripheral neuropathies, less understood, but yes, neuropathy can cause tremor, including diabetic-related neuropathy and so forth. Toxins. This is a little bit better understood, and we're getting more understanding as time goes on in certain toxins and exposures, perhaps leading to a Parkinsonian type of event. Now we understand more of these drug-induced. We commonly see that with tardive dyskinesias and tardive-related extrapyramidal symptoms as well. And there's a whole large list here, of course, of medicines that can cause Parkinsonian tremor or like tremors. And then, of course, psychogenic disorders. So on the other extreme, meaning not necessarily malingering, but also can be conversion reaction. psychosomatic. So this is interactive. What is this? What type of tremor? This is the old Archimedes circle. So you have your patient either reproduce this. Oops, I went back. Or just trace it, and then you're going to get a bunch of waving lines. Any ideas what type of tremor this is? This is essential tremor. Very high frequency tremor. We'll hit the frequency ranges in just a moment, but this is just very scattered. Wouldn't be able to draw. Of course, this is a probably later stage ET rather than early, because we know ET progresses. So frequencies, this can be a helpful clue clinically. Typical range, now I'll say typical with a lot of caveats as we go along. We see a great deal of variation with frequency. In Parkinson's, or the Parkinsonian types, and this is not idiopathic Parkinson's, but the Parkinsonian tremor is the typical pill-rolling tremor. Typically starts unilateral, usually in the arm, and it seems interesting, which explanations haven't been able to satisfy me, dominant side first. And then, of course, it spreads, evolves the other side, and of course, the legs are involved and so forth at some point as the disease progress. But we do have a Parkinson's sort of frequency that we look for, 4 to 6 hertz, typically. There's, again, a range to that, as there is, especially with essential tremor. And this is what makes it difficult, as distinguishing the type of tremor between frequencies. Now, typically, for your run-of-the-mill familial tremor, you're looking at a frequency around 10, 8 to 12 perhaps, but again, reports of 4 hertz are described as well with essential tremor. A little bit more obvious are your cerebellar type of tremors. This is more typically seen in multiple sclerosis. I commonly see this in my office. So these are young females typically that may have a little dysmetria. You identify an examination. Well, sure enough, that dysmetria often corresponds to a kind of a very low frequency tremor. So distinguished from ET, PD, and so forth very well. And quite often these are patients with speech output problems that are consistent with their cerebellar dysfunction, in addition to limb ataxia. Orthostatic tremor, kind of in that realm of ET as well, little higher frequency. And if you're not familiar with orthostatic tremor, well, it's essentially more or less a whole body type of tremor, but it seems to be associated with positional changes, more so standing. And patients more often kind of internally have that feeling, whereas you don't see it so much, and you can see it if you pay attention, but you more often, it's just a subjective experience. This person feels they're standing and then are shaking. But quite often you can see it in later stages nonetheless. So it kind of gives you an idea on frequency. Well, how can we objectively assess this? Well, there's an app for that. There's actually quite a few, as I discovered this morning. I was very interested. Well, is there a way that we can objectively assess this rather than throwing an EMG needle into a person and other very expensive tests you can actually acquire in your clinic? Is that necessary? Well, clinical observation experience is the most helpful guide. But if you're interested, there's an app for that. I can't even read it's not even up there, but never fail. So I downloaded it. I wanted to try it myself. It's called, if you're interested, Lift Pulse. Oh, I guess, it's not on there, but you can download among many other apps that do show, and actually I tested it myself this morning, frequencies. And of course, I mimicked the best I could between PD and ET in those frequency ranges, and sure enough, I felt like it was pretty accurate. But probably as sensitive as what you can determine just observing your patient or have them do a few exercises. I think that's pretty close enough too. But again, there's an app. So back to the drawing board. We have these 4 types, or rather 3 that's illustrated here, but of course many more types. But the old Archimedes circle can be very helpful in determining the type of tremor. So now we've seen the essential tremor type, very high frequency, still pretty regular that is with an R. Parkinson's, quite often regular, but you've heard of hypographia. And so this is a feature that we're seeing here with this tracing as hypographia, or rather the small writing that develops over time. Their signature becomes smaller, and generally their writing is smaller. And then you follow this along too. You especially have them make their own circle, and this is what you're going to get, something small. But you can capture some, well, this isn't the best circle, but some regularity to this tremor. Then dystonia, which is not so regular. And of course, there's many, many types of dystonia, but that's just one example. So let's focus a little bit on Parkinson's disease itself. So this is the old chronic progressive neurodegenerative disorder, also known as a shaking palsy, first described in 1817. So still remains a clinical diagnosis. There's no particular serum test we can run. Is there imaging? Yes. Can it be helpful? Sometimes. So, cardinal signs, bradykinesia, meaning slowness of movement, yes, generally starts unilateral. Second, rigidity and tremor. They often correspond. More obvious is the tremor, and that is usually what patients are complaining about. I have this tremor. I notice it when I'm at rest. Sometimes it happens with action, but more often I'm just sitting there and this tremor is going. And they don't really report as stiffness or rigidity, but of course on our examination we can readily identify that. The typical pronation supination test, you have them sit, and while they're sitting, you want to grab their palm or hand and essentially do that. You want to supinate and pronate to get a good feel starting at the wrist, go to the elbow. Now, I did this with my PA this morning with the patient essentially diagnosed with an orthopedic tremor. Well, okay, you can get muscle and nerve causing tremor, but I got very curious, and as soon as I opened the door, I could recognize Parkinson's by what? The flat facies, mass facies. But, so, he had not much of a tremor, and just I noticed a little bit of flexor tremor with a couple of his fingers at rest. That was about it. And so, sure enough, as soon as I did the supination pronation test, checking his tone, there is very obvious cogwheeling rigidity. So cogwheeling is that old term that we use. Essentially, that just represents a tremor, the activation of agonist-antagonist muscles at hand in a semi-regular but unsynchronized manner. So, tremor and rigidity, again, cogwheeling, rigidity, and tremor often go hand in hand. Postural instability, this is a later event typically. And so this may start even after years of onset of tremor. The old clinical index gives us 2 out of 3 of these, bradykinesia, rigidity, and tremor. So 2 out of 3 meeting the criteria for Parkinson's. Solely progressive disease, however, and demographically, categorically, we can see that slightly higher in males and females, not too much. I think the reason for this is not necessarily X-linked or genetic, but maybe looking at the work environment and so forth, what men may be more exposed to. That's just a theory. But looking at age, this is shifting. This graph is a little old, 2002. I think we can essentially see everything shifting clockwise on this graph now, meaning we're seeing younger people with Parkinson's. Is that due to better diagnostic means and so forth? Better awareness, perhaps, thanks to Michael Fox and others. There's more awareness about Parkinson's. But typically onset around 65 or so, but the prevalence identified between 65 and 75 for the majority of these patients. Disease stage, well, again, early to moderate and advanced, just as we would see with any neurodegenerative process. So, Parkinson's disease is one of the most common neurodegenerative disorders worldwide. Yes, more common than Alzheimer's. Basis of PD, everybody, who do you see? Can you name these figures? Again, we're interacting here. Anybody recognize this gal? Yeah, all right. Yeah, thanks. How about this young person? Cash. All right, got some Cash fans here. Thank you for that. I needed that. Everybody knows Muhammad Ali. The very young Michael J. Fox. Of course, many of us very familiar with the Pope with Parkinson's. How about this guy? Any basketball fans? NBA, Phoenix Suns, Lakers, had retired pretty early because of his Parkinson's. Brian Grant. Charles Schultz, Peanuts. If anybody's looked at his history, you follow the Peanuts, you can see where his Parkinson's started to develop, interestingly enough, still illustrating with his Parkinson's. Janet Reno, Wallace and so forth, Billy Graham. So, but because of those faces, this is why I have a lot of this data to present, by the way. We've seen not just Michael Fox, he's probably one of the big breadwinners for Parkinson's research. Muhammad Ali, Linda Ronstadt has her own organization as well, but Brian Grant as well. Large funding collected for research and treatment of the Parkinson's disease. So I covered some of the demographics, but in terms of incidence and prevalence, we understand it's very common. Again, we're looking at big numbers, 1,000 to every 100,000 persons more than 65 years old, half of that for people over 50. So many cases remain undiagnosed. And probably one of the reasons is, well, is this Parkinson's? Is this idiopathic Parkinson's? Is this something else? And so sometimes we like to wait. And I'm guilty of myself. Guilty in the sense, well, sometimes we have such mild symptoms. I often tell my patients, well, the tincture of time can sometimes be the best diagnostician. Meaning dealing with movement disorders, not easy, not even among my colleagues in movement who specialize in movement disorders. It can be quite perplexing. And so we do have an array of these tremors, no less. I mean, we saw the classifications, etiologies of the tremors. It actually expands that list considerably. But then we have the so-called Parkinson's plus syndromes. More atypical, the old term, but Parkinson's plus. This is not a comprehensive list either, but progressive supranuclear palsy. This is a common mimicker, a little bit more easy to distinguish at later stages because these are patients that don't have pronounced tremor, but they have significant rigidity. These are patients that essentially, the rigidity not just affects their limbs, predominantly symmetric, so when it starts, it affects their arms. So they don't have a lot of movement with their arms, but especially paravertebral and leg muscles. So they're just kind of, they're doing the shuffle, but you're not seeing a whole lot of tremor. And these are patients that at some point are going to have their ocular motor system affected. So these are patients that typically have gaze paralysis, typically starting vertical, up or down, typically down. So these patients tend to fall a lot. So that's one of the hallmarks of PSP. They tend to fall. That's because they're not seeing where their feet are going, especially to have troubles going downstairs, and that's where they tend to fall. So a little different pathophysiology with this, and clinically can mimic Parkinson's very well in the first year. And so quite often I'll have patients with symmetric tremor, just very mild tremor, but a lot of rigidity. Say, well, again, that tincture of time we might have to apply, and let's reassess in a few months. And that I've diagnosed a couple of patients just on those parameters. Multi-system atrophy is quite common, and this is where it sometimes can be confusing as well with idiopathic Parkinson's. But MSA, we used to segregate this into 3 different disorders. Now it's just kind of lumped all together in one. We call it MSA more or less for convenience, but because of those other syndromes, oligopontal and cerebellar and substantia nigra, all of those get kind of, there's a lot of overlap and can be quite confusing. So still used for research when we're looking at pathology specifically, but it's very convenient now to label this as MSA. Shy-Dragger type, you probably have all seen Shy-Dragger. Why? These are patients with a lot of complaints of dysautonomia. These are patients with orthostatic hypotension, predominantly, and of course many other orthostatic issues. So we have to keep in mind of MSA, especially in the setting of significant orthostatic hypotension. Not a lot of tremor with them, but quite often have symmetric tremor as well. And again, a progressive gait disorder at hand, and that's predominantly the problem and complaint. These patients can get cognitive problems at some point, but it seems to be somewhat preserved for a longer duration than your idiopathic Parkinson's disease. Contrary to diffuse Lewy body disease, DLB, these are patients that tend to lose cognition early on. And in fact, the criteria for a distinguishing DLB from idiopathic Parkinson's is you have just that cognitive dysfunction perhaps within a year, and it's really that surrounding year, plus minus 1 year of Parkinson's, or the typical motor manifestations of Parkinson's disease. What sort of cognitive dysfunction? You're going to predominantly be assessing for visual spatial dysfunction. So these are patients that may get lost, disoriented graphically, but even writing. A simple and quick examination you can do right in front of the patient is have them recreate hand constructions. Make a triangle, flip that, put your fingers together. If you identify that a problem in your maybe Parkinson's patient, but early on they're having a hard time reconstruct things graphically or by hands, that's a pretty good indication that maybe more is going on. The other hallmark of DLB, these patients tend to have a lot of sleep problems early on, but we're going to get into the Parkinson's as well with sleep. But these patients have REM intrusions. So if you're familiar with REM sleep, we get the crazy dreams, so-called hypnagogic hallucinations. If you know narcolepsy, well, these people are getting REM intrusions. So I had one patient, she was 68. She had a mild tremor, but her husband recognized a lot of memory problems and disorientation issues. And so my first question was to her, do you ever get people coming to see you that may have died? Oh yeah, happens all the time. So these are quite familiar hallucinations, familiar faces, people they know. Spirits, as they may report, come see me. And sure enough, because of familiarity, these are family members and so forth, these are actually formed hallucinations, and quite often these REM intrusions, they're dreaming. But of course, they have the awareness of their environment. If you know narcolepsy, it's a very similar type of REM intrusion. So quite a distinction. I got to keep track of time. I may be just rambling on too much. Got to get moving. Oh, Lewy bodies. Yeah, this is the hallmark pathology with many of these diseases, by the way. This is not specific for Lewy body disease, these Lewy bodies, but we see that in Parkinson's disease. These form Lewy bodies, essentially an aggregation of alpha-synuclein and others, which I'll get to the pathology in a minute. So again, on our differential, we're thinking about many other things, right? Including medicines. So drug-induced, we do have the more common neuroleptic-induced tardive issues, or EPS, so that's always on our mind, as well as other things that are less commonly used that's on this list. What about calcium channel blockers, too? How many of you are aware of diltiazem inducing a Parkinsonian type of problem? Lithium, that's a little bit more understood. Less commonly understood is methyl-dopa. But I was going to ask, are there any OBs here? Oh, okay. Well, have you ever seen a methyl-dopa-induced Parkinson's? Yeah, pretty rare. Toxins, and this is where it gets interesting with our local farmers, ranchers, people working in industries exposed to various compounds. Now, carbon monoxide poisoning, of course, you can get that in any arena, especially if you're a truck driver sleeping in a cab with a hole in it, running in the car all night. And I had this patient with this very problem, developed Parkinson's, that was irreversible. So carbon monoxide poisoning, ethanol, methanol, manganese, something I often routinely test in young patients, especially if they work in industry, various industries. Cyanide. And then we have to question spousal abuse, but the MPTP, this is if you're not familiar with MPTP, this is kind of how we identified PD on the mouse model by these people in San Francisco consuming recreational drugs, laced and so forth, developing Parkinson's problems. So they modeled that, and so we've developed a mouse model for Parkinson, although different, but it has been helpful for research. Now, of course, all sorts of liver problems, hypocalcemia, Parkinson's, hypoxia, infectious diseases, including the plethora of CNS infections, AIDS, Creutzfeldt-Jakob disease. Usually have a lot of cognitive problems preceding or at the same time of Parkinson's. Now, this includes all sorts of other things, including post-encephalic Parkinson's and so forth. ADEM, which is acute disseminated encephalomyelitis, post-streptococcal neuropsychiatric disorder, encephalitis lethargica, and so forth. Sydenham's, I actually saw one case in residency was all. Infarct disease, of course, and you have evidence of basal ganglia surrounding territories of infarct, and then you have essentially stroke-induced. Biswangers is something that we tend to underappreciate as well. Mechanical infiltrate trauma, syringomyelocele, encephalitis. Again, these are younger pediatric population. We're talking about hydrocephalus and all these others, except for NPH. Then your differential is quite broad in the elderly, especially if they have a magnetic gait, dyspraxic gait. Meaning, has anybody seen an NPH patient with a magnetic gait? It's very impressive. You have them stand up, and if they're lucky to get out of their chair, great. But then they're just like this. They're trying to move that left leg. And it literally looks like a magnet stuck on the heel of their foot to the floor. May not be as obvious, so with NPH, but normal pressure hydrocephalus can manifest in many ways, but typical a dyspraxic type of gait, meaning that those connections, voluntary connections, are not working so well. Of course, tumor and so forth. I'm not going to go over this extended list, but essentially you have a lot of degenerative disorders that correspond with genetic problems and so forth, including Huntington's disease, Haller-Vater spots, iron accumulation within the basal ganglia, Wilson's, and so forth. Again, that may be intimidating to you, but it's certainly intimidating to me, that whole list. This is where, when patients come to us, well, is this something else going on? Well, yeah, there could be 100 different things going on, and it's very intimidating to me still. So a lot of possibilities, no doubt. So back to biochemistry in medical school, understanding dopamine synthesis and metabolism. Again, what we're focusing on predominantly is dopamine exchange. Synthesis and metabolism, so starting with the presynaptic terminal with tyrosine, amino acid that we all need, essential, and then using hydroxylase to convert tyrosine to dopa. Then dopa, decarboxylase, essentially forming dopamine entirely, which can be exchanged to the postsynaptic terminal, expressing D1 or D2 receptors. And from there, we get a G protein signaled response. Now, what happens to the dopamine back in that synaptic terminal? And between where it gets metabolized, we have monoamine oxidase enzymes and COMT enzymes. And of course, that gets converted further and eventually metabolized to homovinylonic acid. Now, this can be uptake otherwise, and so this is an important slide because now, soon we're going to be talking about medications that can have some interaction at one of these levels. So, important biochemistry, all of us like to retain because it has clinical relevance. And I'm just going to keep moving forward, and the dopamine's dancing all around. Okay, pathophysiology of now this is very interesting if you are interested in neurochemistry because there's more and more information on this subject as time goes on. So this is essentially, though, in a snapshot. I try to put all this in kind of a snapshot, of course, to make it useful for everybody. Degeneration of dopaminergic neurons in the substantia nigra with a strong caveat, not just there, leading to loss of dopamine. Now, this is an important point that I'm going to really weigh on for the next few minutes. Loss of 50%, more than 50%, of normal striatal dopaminergic innervation results in manifestation of symptoms. So we're missing quite a few of these cells by the time, and this is more typically the motor component, motor manifestations, and vellus cell. And of course, at this time, we start to get those Lewy bodies developing. I'm not going to go into detail with alpha-synuclein and other composites into this, but it's a very interesting science. So again, I kind of led on to herbicides, pesticides, other environmental factors. So it seems to be commonly associated with rural living and well water consumption, which kind of worries me right now because I'm looking at property in Huntsville, right, on a well, because there was just a study released on this very topic that we've kind of had an idea for many years, but now, again, a very clear, an association, not a clear cause and effect, but a strong association of rural living near farmland, well water, and so forth seems to be a substantial high risk. And so northern Utah, as the environment we live in, unfortunately, we do see a fair number of Parkinson's patients. Demographically, I haven't seen the studies to see how we rate compared to other areas of Utah or nationally as well, but Fair to say, I think we have a very substantial population here. Reasons for this? Well, again, very interesting science, oxidative stress through a defective antioxidant system, predominantly weighing in on the mitochondrial system. And this is essentially what we're looking at with glutamate exocytotoxicity, reduced glutathione levels, and again, increased nigrobasal lipid peroxidation. This is actually a lot of science is going right into this, exudation, peroxidation with nigrobasal lipids. So a lot of interest in lipid formation and so forth. But ubiquitin proteasome system, again, has been pretty well understood and continues to be better understood as we're talking now. A lot of references there if you're interested. Then genetic, of course. Now, the whole Parkin gene, if you're not familiar, we seem to be getting more and more identities of the Parkin gene in itself, where in general about 10% of the population may have some form of genetic or inherited Parkinson's. Usually it's young people manifesting in some lineage, and quite often we can identify a Parkin gene, and especially in these younger people. So is it genes plus environment? Possibly so. Of course, genetic alone can do it in that small, again, very small population. The question always to me is this inherited? Grandpa's got it. Am I going to get it? The answer is, I don't know. We can do genetic testing, but we understand the utility of that. So let's go over symptoms. This is the more common motor manifestation, an extended list from what I introduced. So the tremor at rest, bradykinesia, rigidity, micrographia I've talked about, hypophonia. Any questions on that? You get the mimic speech, the hypomimia, as well as a hypophonia. Many people have claimed I'm hypophonic. Can you hear me back there? I'm not so hypophonic, maybe. Okay. I didn't get a response. Maybe I am. Or I just put people to sleep. That's my other habit. Being a sleep doc, I guess I have to do that. But I kind of demonstrated that the typical shuffling gait very minimally, but yeah, it's a very slow-paced shuffle. Usually, because of their postural instability, they're very cautious, and although it can be broad-based, and for that reason, because they just don't want to fall. Now, usually, it's the get up and go that's the problem. Once they get going, then they can have a hard time stopping. Again, because of that bradykinetic component. And once they get going, then they can't turn on those agonist muscles to get them to stop quickly enough. Slowing of activities of daily living and decreased arm swing. This is a very helpful test, by the way. Just have them walk your hall, pace it a couple of times, and just watch their arm swing. Now, typically with an involved limb, they're just going to not, I can't demonstrate that. I'm good with everything else, but they're just not going to swing their other arm. Or if it's very severe, then it's a little bit more obvious, you know. And so the affected arm will show that. Sometimes more evident on gait examination than sitting down with them and testing their tone and looking for tremor. So I mentioned the stoop gait, and that goes along with the other bradykinetic features that you may see, including mass faces or the simian posture. So all of that together. So quite often they get hypertonic in areas, or rather hypertonicity involving even abdominal muscles, and that tends to pull down on their spine as well and create spinal issues, and I've seen that time and time again. And so a whole host of motor manifestations. Typical, usually pretty easy to assess in your clinic. We don't need any fancy tests. What about the non-motor symptoms? And this has a particular interest with me because many of these non-motor symptoms can manifest many years earlier. Now, of course, they're going to manifest during and at later stages of the disease process, including cognitive impairment, more typically later with Parkinson's, depression, typically earlier. Fatigue, common all throughout stages, anxiety, sleep disturbances we'll look at, sensory symptoms, including pain in how many of these patients? Have you done a cardiac workup for left or sometimes right arm pain? And you'll see why. Dysosmia or anosmia, poor smell, that typically is an early feature. Akathisia, color vision, this is a newer topic. So among the many sensory problems is disturbance of color perception. Non-motor symptoms continued with autonomic problems I kind of led to early, but including orthostatic hypotension. Yes, even in idiopathic Parkinson's disease, So not necessarily or exclusive to MSA, but also PD. So excessive or hypersalivation, salivarias, so they have poor muscle control of the facial muscles. But there's other elements to this, purely autonomic, that cause them to salivate more so. Dyspnea, seborrhea, diaphoresis, sexual dysfunction. Constipation is one of the leading concerns I have to deal with on a daily basis with these patients. In fact, I'll just focus a little bit on the more recent 2010 at least, practice parameters produced by the American Academy of Neurology. They really did, I guess I'm going to just introduce that now just because we're on this subject here. They only came up with 3 kind of non-motor symptom management suggestions because the evidence is lacking for everything else essentially. But they actually suggested Viagra. That was on one of the 3 interventions. Treating constipation with Miralax, and I'll get to the 3rd. But of all of the non-motor symptoms, there's really just the 2 that they recommend in terms of medications specifically. Okay, so going back to our tremor. So we have this young man in our office, well, young 40s maybe. He's shaking away. So what about those common non-motor symptoms with Parkinson's? Does that help us distinguish essential tremor? Maybe, maybe not, because unfortunately with essential tremor, they have a lot of non-motor symptoms as well. And that's why this slide, I want to make that point. It can be a challenge between ET and PD. Well, that's why many publishers are saying that ET is essentially a risk factor for PD. Essentially what we're saying with that is they probably do have Parkinson's, but not manifesting in a very typical manner, so we label them as ET. But more prevalent, however, according to this recent publication, is showing that these non-motor symptoms are just more common with PD. And so in terms of drooling, more common with PD, as is hyposmia, poor smell, and hallucinations when we talk about REM intrusions. We'll get into that. Difficulty with concentration, other cognitive issues are just going to be more common with PD versus ET. Again, not excluded with ET nonetheless. Falling issues, vivid dreaming, again, we're talking about REM sleep and REM behavioral disorder specifically. So, from my perspective, if you can sense that I'm favoring anything to help us distinguish ET from PD, look at these sleep problems. And that's what I like to look for as well. That may be my other interest in head is sleep disorders, but my interest in sleep disorders actually started from Parkinson's because there's this overwhelming overlap with the sleep disorders, including REM behavioral disorders. So this was one of my interests in fellowship was actually looking at REM behavioral disorder. Natural history, I'm not going to spend a lot of time. Yeah, it starts mild and gets worse as we go along. It's a progressive disease. But typically, obviously, the older you are onset, the more progressive things are more quickly, things will decline. But early stage, mild symptoms, activities of daily living not significantly jeopardized by any means. We get that honeymoon period, treatment adequately controls symptoms, so a little bit of Mirapex takes care of it. Moderate stage, we get the fluctuating response to levodopa. So the waxing and waning symptoms, as referred to, the symptoms that affect activities of daily living in addition to more intensive treatment, so more frequent visits, dosing schedules with sentiment and so forth. And then the advanced stages where we get symptoms that resist all available treatment, and of course then we get medication complications corresponding with that, and then of course disability, freezing, falls, cognitive issues, ultimately. Now, this is a slide that I think requires some attention. Again, recent publications showing the beginning of dopamine depletion. Now, what percentage can we say? We don't know. There's some guys doing the research down the road for a month looking at this very question. But what we're talking about, these non-motor symptoms may be developing 5 to 20 years. I wrote 15, but even up to 20 years on some reports of early manifestations of Parkinson's. Well, we didn't really ascribe to Parkinson's many years ago, but now we probably should. That includes REM sleep behavioral disorder, depression, anxiety, often corresponding with other pain syndromes, which makes up the plethora of all of our practices. You're depressed, you have pain, you can't sleep. Well, okay. Do you have Parkinson's? No, not necessarily. That's not what I'm saying. But we'll have to put the whole picture together, put all these pieces of the puzzle. Now, my interest in sleep was this. Parkinson's disease, we looked at it, well, essentially, Carlos Schenck and Mahalwood out of the university, they had this interest going back even to the 80s, but a lot of their published literature came out in the 90s, and then while I was doing my fellowship, showing that a lot of these, what we titled as REM behavioral disorder patients, idiopathic that is, specifically, meaning they had no comorbidities, but a lot of these patients, by observation, were turning into Parkinson's. So they decided to follow these RBD patients very well. And so we have the best data coming from Minnesota showing essentially over a 70% risk if you have idiopathic, as labeled previously, idiopathic RBD, over a 70% risk of developing into Parkinson's. Timeline of that varied considerably. It could have been 5 years, it could be 20 years before they develop Parkinson's motor features. And so, a very large interest in the scientific arena, especially among sleep and movement disorders people, looking at and actually identifying degeneration with these patients. Ventral versus dorsal degeneration. So if you look at the substantia nigra, I wish I had, well, I couldn't because of copyright issues. I like to show a nice anatomical representation when I'm talking about, but essentially with Parkinson's, you get more of this dorsal posterior degeneration, including the substantia nigra and other elements. And whereas RBD, with the locus coeruleus and other nuclei involved, which is more ventral, that's where the degeneration may, in fact, start. So it may just come down to a 0.8, 0.5 millimeter difference in terms of what a person may manifest. And so RBD is, if you don't know RBD, REM behavioral disorder is essentially a disorder of sleep, of REM activity. So these patients enact their dreams. And unfortunately, the predominant of dream content is quite aggressive and often violent. And in fact, I had a patient come to me yesterday with this very complaint, more so a complaint from his wife, because he's sleeping during this, but she's getting beaten up. Literally. She's woken up with a fist in her face, with hands on her neck, and she's a little worried. He's fine, he's sleeping, although he does report, yeah, pretty intense dreaming, man. Quite often, unfortunately, these are patients maybe have served in the military. Of course, PTSD is always in the differential with this, but we can objectively look at this and assess for RBD. Essentially, in a nutshell, what we're looking for is increased phasic REM activity on the sleep study. So we look at REM, we look at surface EMG. Often we include it on the legs as well as the arms, in addition to chin EMG here. And we look at REM, and during REM, what you see is just a lot of that motor activity breaking through. And there's actually a set criteria for that Carlos Schenck developed along with Mahalwood, and determining if this is normal or not. Now, of course, the sleep study is one thing, but history is a very helpful thing. So essentially, the rule is you have dream enactment, and that quite often you can. You don't have to recall the dreams, but essentially mimicking what's going on in the dream, and quite often violent at that. And this is essentially categorically a REM parasomnia. As just we can, REM parasomnias are not common in terms of the number, but the REM behavioral disorder is one type of REM parasomnia that's readily identified through sleep testing. And treatable, by the way. But again, according to Schenck and Mahalwood studies, I'm sorry I don't have my references down below, but if you're interested, the University of Minnesota has a plethora of studies from these guys that have been very useful in the movement disorder arena. Anosmia, that's kind of my home bench work also at Northwestern, where we're showing anosmia or dysosmia in patients with Parkinson's many years before. Nothing very accessible there is actually testing that can be arranged, but nothing very practical in terms of reimbursement and so forth, and to actually have objective testing, but sometimes I think history is more valuable anyway. And depression, anxiety can be a very common manifestation early on. And there's actually a host of others. I just kind of listed the more common non-motor symptoms that may predate the motor symptoms overall. Again, what are we looking at? 15, 20 years. And so many universities have a strong interest in this because, well, I can't cure Parkinson's, but I think someday we'll come up with a good neuroprotective drug or something that may be important to identify PD early on and treat them so we can protect more of those substantia nigra neurons. Well, so mortality, yes, a bigger issue with PD by some, largely due to complications and largely due to aspiration pneumonia. Of course, with less activity or higher risk of PE, complications from falls is very, very common. And of course, a urosepsis, ultimately, when they come into the CCO, is an issue. I'm not going to weigh in on the genetics. We talked about that. Quality of life, health-related quality of life influenced by mental than physical factors more so. And symptoms of PD and disease progression. Essentially what you're going to do is you're going to be following these patients, and it's tragic for me. I'll have these patients since I started practice in Ogden. It's coming up 8 years now, and they still see me for some reason. And it's, for me, being a starting physician, like many of these neurodegenerative disorders, just to see that progress and how things go, and losing their job, and how it affects their family life, and so forth. It's a terrible disease, yes, but something that we can help manage along the way for many years, despite other neurodegenerative processes at hand. But predominantly what we're treating, maybe their sleep, maybe motor fluctuations and so forth. So that takes us to treatments, which, how much time do I have? 5, 10? Okay. So quickly on treatments, only a brief amount of time on this anyway, because nothing earth-shattering has come out in the last few years, just kind of tweaking old agents and trying to make them a little bit more practical, perhaps. Dopamine agonists may be considered first line. There's others first line too, but more traditionally, perhaps first line. And we're talking about medicines like pramipexole, ropinirole, Mirapex, Requip, branded, but now all generic with those two. The more recent one is the Nupro patch, the patch that you can apply on a daily basis. Dopamine agonists all carry very similar side effects. A little bit different exchange if you're going through the liver or the kidney with ropinirole versus pramipexole. But essentially all of them will cause nausea to some degree, dizziness, orthostatic hypotension, edema, and drowsiness. They're all sedating. We like to use those for restless leg syndrome, don't we? Because it puts a patient to sleep, among other factors too. But we want to advise with dopamine agonists, such as Mirapex or pramipexole, ropinirole, we want to take it with food to minimize the nausea. That can be helpful. We have to warn them about orthostatic hypotension, so get out of bed slowly. Turn on the lights, because we want to use visual information as well, since you're probably ataxic anyway. But you want to just sit at the edge of the bed for some time until you feel comfortable standing when you have to go use the bathroom at night. The ergot-derived dopamine agonists, we just don't see it around because the FDA took a lot of them off, and if one's available or not, they're hard to come by, highly regulated, and I've never used them, so please don't ask me on ergot-derived dopamine agonists. We got a bad taste in our mouth during training from our movement specialists who saw too many complications from that, and so the FDA kind of stepped up. Bromocriptine, kind of mixed. You get other side effects with that, not advised for the elderly, very old people. We'll go on. Carbidopa, levodopa. Everybody's familiar with the sustained release formulation. My opinion, not much better. Have I tried it at night? Maybe so. The problem is bioavailability with the sustained release. It's highly variable, so not very reliable, and can be a little bit more pricey, although it still is generic. So typically with carbidopa, levodopa, I start at 150 rather. You can start with the 50s. Carbidopa, we understand what carbidopa is. It helps prevent the breakdown early on of levodopa. But the other advantage too is a little bit more carbidopa can minimize the nausea that you're going to get with cinnamon. And so a little extra carbidopa can help. Keep that in mind. You can buy carbidopa by itself, by the way, so you can scribe that. And that can be helpful for nausea especially. And perhaps even give a little bit more sustained effect with the cinnamon. Of course, we gradually titrate as needed, up to 3, 4, sometimes 5 times a day. We can get up to very high doses. What is the problem with that? Dyskinesias that we'll get into. Careful with high protein meals because that bioavailability is limited with protein and its absorption. So maybe not a problem early on in the disease, but later on, if you need additional help for control of fluctuations, waxing and waning of the motor symptoms, you may advise minimize or avoid protein consumption a half hour or 45 minutes when you take your pill beforehand, and maybe even up to 2 hours after you take your pill. Amantadine, kind of the dirty drug, but anticholinergic effects, again, something we may avoid in the very elderly because of confusion and other symptoms, but it can be very helpful for tremor. And sometimes I use this as first line for just a very mild tremor in a young person. And then I may come back to a person with a lot of dyskinesias due to their levodopa. Have you all seen dyskinesias from Cinnamon? They can be pretty violent. And we're talking, they're just a fraying dyskinesia. They're just wiggling, and I've had a patient just stumble and fall and hit herself from these dyskinesias. So backing off on a little bit of the levodopa and then adding amantadine can be quite helpful for that. Then we have the monoamine oxidase inhibitors, and selegiline and rasagiline, both are approved for Parkinson's. And rasagiline can be considered a monotherapy as well. Mild effect, but can be helpful as adjunctive therapy as well, or perhaps as first line. COMT inhibitors, we generally reserve this as kind of later on. We want to improve the waxing and waning, so the steady state pharmacokinetically, we can add on a COMT inhibitor. This is such as entacapone is more commonly used rather than talcapone. And entacapone can be added into a drug called Stalevo, so you get essentially 3 drugs in one, the carbidopa, levodopa, and entacapone, to make it convenient. I don't typically do that, generic. And you can give entacapone with the regular sentiment, that's no problem. Again, the goal with this is to add duration to the effectiveness of the levodopa. What about advanced treatment? Apomorphine, this is an injection for the frozen periods. So we're frozen, I can't move. Can you move enough to inject yourself with a syringe? Then we can provide apomorphine. A low protein, going back to cinema again, low protein diet may help. Amantadine for the dyskinesias as mentioned. Painful dystonias, we may have to resort to muscle relaxants of various types, including baclofen and also Botox if needed. Trihexyphenidyl has its role, helps tremor, but can cause other problems too, side effects in terms of confusion and other problems in the elderly. So I'm not going to spend a lot of time on the surgical options, only because, well, I dive into medicines, I don't do the surgery, but there's an abundance of data for DBS. And when I was in school, it was kind of the last resort. Well, it was very early on in research. Now we're seeing more and more reports that maybe we should consider deep brain stimulation early on. And there's some convincing data. And I think we may be going that direction. Typically, we wait with DBS for patients that have drug resistance, Parkinson's, and all the complications that come with the drugs, all the violent dyskinesias. So we like to get them down on their medicine, but they have too many frozen periods. So then we used to send them for DBS. Now that threshold is coming down. We may consider surgical options much earlier. And so I think we're seeing data to support that. Ablation, pretty much not done anymore. You know, Michael Fox had his, and there's a reason why he went to double DBS. So there are other procedures, by the way, that I wasn't going to go through. Devices to help with tremor. I thought this was a cool thing. How many patients have problems eating because of their tremor? They have devices that can help. I'm not going to give the product name, but you can go online and find products that help patients eat. Keep their Cheerios on their spoon and they can eat. How about that? A lot of neat, nice gadgets out there. The whole message, I think, with this is our understanding of Parkinson's is improving. Treatments, unfortunately, are not outside of the surgical realm. That's where we're seeing much more headway. But today, let's focus on non-motor symptoms. Let's help our patients. It's more than treating the motor problems, but it's also look at their sleep, their cognition, mood disturbances, and so forth. Recognizing those maybe give some reassurance that this is part of their disease process. Maybe that's part of their therapy anyway, that we respect everything altogether that's going on with their Parkinson's. It's maybe a multi-system disease, not just isolated to the substantia nigra as previously thought. Well, questions? Yes? Mm-hmm. Okay.
Excuse me for just a minute. So I'm taking over for Heather. In case you couldn't tell the difference, she's much better looking than I am. A couple of quick announcements. Excuse me for interrupting, Dr. Hammond. First of all, 6 o'clock is the gathering at the Dinosaur Park for you and your families. If you're going to go to the President reception tomorrow, please pick up tickets for that. You're welcome to come, but you need tickets, and you can get those at the registration desk either this afternoon, this evening, or tomorrow. Thank you. Back to you, Dr. Hammond.
So the case is we got profound orthostatic hypotension and then the development of Parkinsonian features at some later point. Very late, okay. Well, and the question is, what does he have? An autopsy revealing Lewy bodies. You mentioned that, but was it in a specific area? Yeah. So was that multiple? Okay. So of course you can have. So of course early on you can have autonomic disturbances with idiopathic Parkinson's, but always with such intense orthostatic dysfunction. I'm going to be looking at multiple system atrophy, Shy-Drager type, and so forth in those patients, yeah. And typically, that's the case. Their autonomic dysfunction starts first anyway. It's just not recognized unless you really ask. Yeah. Uh-huh. Yeah. Okay, well, that takes us back to the American Academy of Guidelines again, recommending some therapies. Unfortunately, specifically for Parkinson's, they couldn't recommend it in terms of midodrine and fludrocortisone, salt tablets, and so forth. They just really commented on, supportive care for these patients because there's really no evidence specifically for Parkinson's. But yes, I use all those products, including Mestinon, especially if they already have supine hypertension. Mestinon's a good idea for those patients to provide some vascular support. And of course, there's Indocin, so you use the anti-inflammatory prostacyclin inhibitors and so forth to help with OH, and stockings and so forth. The list goes on. But yes, symptomatic management, although specifically for Parkinson's, not a lot of data, or at least sufficient data in my mind. Still treat the symptoms though. Yeah.
Is there any reason to not be too aggressive early with Parkinson's disease, with the theory that you're going to burn through your medicines too quickly and then have nothing to go to?
I appreciate you asking that question. Is there a problem with starting a particular agent too early due to tachyphylaxis, and maybe the question, or developing tolerance, or drug resistance, Parkinson's, and so forth? It is a big, big question in the movement disorder journal. You pick up any journal, it's always a topic. And the answer to that question is, I don't know, because I've gone back and forth with movement disorders. Everybody has a different opinion. Should I start with Mirapex before Sinemet? What about vice versa? When we talk about neuroprotection, every single drug has data. Of course, we know the rules of statistics, but every single drug has data showing it's, quote, neuroprotective. So we don't have the risk of tachyphylaxis and so forth. And so I've been just beating my head on that whole topic. What should I do then? Because there's even data, because in my training I was told, we got to hold off on Sinemet and start Mirapex first, and then use Sinemet as kind of a last resort. And that was based on those studies back then showing tachyphylaxis with Sinemet and so forth. Well, newer studies show that's not the case. So my approach to that is I believe more so that Parkinson's is a progressive disorder. It's going to progress no matter what we put on. Is any agent considered neuroprotective? The answer to that is no, at least per FDA. It's been submitted a few times, especially with one drug, submitted but not approved. So my approach is that is a progressive problem. We don't have a drug that's neuroprotective. Are we going to hurt them by starting one instead of the other? I don't believe so. But I think we'll see more data on that very question. Yes?
What recommendations do you give families with genetic potential that are asymptomatic?
Well, how do we know there's a genetic potential?
If there's a really strong familial incidence of
Yeah.
it?
Yeah, I think my approach is just like anything else with genetic testing. Well, we can offer it if that helps you in some way. But there's always the caveats with genetic testing, which takes us to the old ethical question with that. I haven't typically offered it. Most of my patients are very curious anyway, but there are very specific genes. If there's any interest specifically for Parkinson's, I'd probably be sending them to a neurogeneticist to really answer that question better for me than I can. So I don't get into that. Thank you for that question. Thanks, everybody. Appreciate it.